everyone, my name is Fatima Habib, and today I'm going to be talking about cancer risks related to low-dose ionizing radiation from cardiac imaging in patients after acute myocardial infarction. Looking at an overview of our presentation over here, first we're going to be talking about if low-dose ionizing radiation from cardiac imaging after acute myocardial infarction does lead to an increased risk of cancer. Second, we're going to be talking about how we can use the hospital discharge databases to build our study cohort and also conduct statistical analysis. Then, during the results, we're going to discuss how 12,020 incident cancers were detected during the follow-up period. And finally, we're going to conclude that high levels of low-dose ionizing radiation from cardiac imaging does lead to an increased risk of cancer. Looking at the first part of our presentation, does low-dose ionizing radiation from cardiac imaging after acute myocardial infarction lead to an increased risk of cancer? So what's interesting is that studies involving atomic bomb survivors have documented an increased incidence of radiation exposure. Similar risk estimates have also been estimated among workers in nuclear plants. In the past 6 decades though, although the atomic bomb explosions have been at an all-time low, most individuals worldwide have also had minimal exposure to ionizing radiation. Yet, even with its associated risks, cardiac imaging has become more and more common in medicinal practice. Newer types of imaging procedures use higher doses of low-dose ionizing radiation than those used with more traditional procedures. And this study aims to discuss the risk associated with patients exposed to low-dose ionizing radiation after acute myocardial infarction and its link to cancer, and the main aim of the study being to directly link cumulative radiation exposure and cancer risk after myocardial infarction. Second, we're going to be moving on to how we can use hospital discharge databases to build a study cohort and conduct statistical analysis. There are 4 parts to the methods. The first part is to build a study cohort. Second is looking at the radiation exposure. Third is the development of cancer. And fourth is the statistical analysis. Moving on to the first part, we used the hospital discharge summary database MedEcho and linked it to RoundQ. Using these 2 Quebec databases, we included patients who were admitted to the hospital from April 1st, 1996 to March 31st, 2006. Patients were then excluded based on evidence of prior diagnosis of cancer, which included admission to a hospital with a primary diagnosis of cancer, a secondary diagnosis of cancer, a visit to the hospital with diagnosis being cancer, or a trip to an oncologist regardless of the diagnosis. The final cohort then comprised of 82,861 patients. Patients were then divided into 5 groups, based on the level of low-dose ionizing radiation. So over here we had our control group, moving on to the group with 0 to 10 millisieverts of low-dose ionizing radiation, 10 to 20, 20 to 30, and above 30 millisieverts of low-dose ionizing radiation. Follow-up incidence of cancer began 1 year at minimum after acute myocardial infarction. This timeline was important for us as it minimized the risk of associations between low-dose ionizing radiation and the risk of workup bias. The sensitivity analyses were performed to explore different time lags between 1, 3, and 5 years between exposure to low-dose ionizing radiation to ensure that incident cancers were not occurring too soon after acute myocardial infarction or exposure to radiation. So after a minimum of 1 year and a mean of 5 years, patients were considered to have cancer if at least one diagnostic code was met for cancer based on the International Classification of Disease. It was important to determine a lack of bias in the study. So the characteristics of the patients were also noted, which is what we're going to see during the results of the 12,020 incident cancers that were detected during the follow-up period. So looking at the data between the the control group, and then the group from 0 to 10, 10 to 20, 20 to 30, and above 30 millisieverts of low-dose ionizing radiation, it was seen that the age was about similar, with the median being about 72.2%, with those with higher levels of exposure being at a younger age. Over here, it was seen the majority of the participants were interestingly men at about 59.5%, but more and more men in the group were exposed to radiation. Patients with higher level of exposure tended to be younger males with fewer comorbidities. It was also important to account for medical background history to account for a lack of bias. For example, if a person had a previous diagnosis of diabetes, it led to an increased risk of cancer. So it was important to note that all patients had a similar background history, which in this instance they were. They differed little. with the mean at about 20.6%. It was also important to note the amount of low-dose ionizing radiation from non-cardiac procedures was similar in each group before beginning experimentation to account for a lack of bias. Interestingly, the control group was about 1.26 millisieverts, but groups who received ionizing radiation from cardiac procedures also had larger values of radiation from non-cardiac procedures. For example, as you can see, those at 0.10 millisieverts were at 1.94 level, which varied slightly. During the results, as mentioned before, it was found that 12,020 incident cancers were detected during the follow-up period. Directing you to this figure over here, to note first, we had our hazard ratio, and a hazard ratio over 1 showed increased risk, and a hazard ratio below 1 demonstrated decreased risk, with the variables on the left. Over here, it showed that for men, the men had a hazard ratio of 1.504, which was relatively high. Age, on the other hand, has a hazard ratio of 1.045, which was relatively lower, but still demonstrated an increased risk. It's important to note here, and this part is most vital to understand, that cardiac radiation increased as the dose increased. So at 10 millisieverts, it increased when it went to 20, increasing again as it goes to 30, and increasing again as it goes to above 40 millisieverts. On the other hand, radiation from non-cardiac procedures had a hazard ratio of 1.008, which was still demonstrated a slight increased risk, but was a lot lower than cardiac radiation. It was also important to demonstrate the frequency distribution of the 12,020 incident cancers by site of cancer. So it was interestingly, the abdomen and pelvis area contained 41.9% of the incident cancers, thorax at 26.8%, head and neck at 9%, bones and soft tissue and skin at 22%, hematological at 8.2%. So this was interesting, as looking at this graph over here, it displays the procedure and the percentage low-dose ionizing radiation from cardiac imaging per the procedure, with percutaneous coronary intervention having the highest percentage low-dose ionizing radiation. And what's interesting to note here is that since these procedures are localized to the abdomen and thorax area, the majority of the cancers were also linked to that area and localized in that specific region. Wrapping up our presentation today, higher levels of low-dose ionizing radiation from cardiac imaging did lead to an increased risk of cancer. And even moderate levels of exposure were associated with an increased risk of cancer. Therefore, for future reference, it is important to be varied and understand the risks of imaging tests before conducting them, as well as properly documenting and referencing imaging tests in regards to safety. That is all. Thank you for listening.